Hindi pa po, Doc.
Okay, so it's 8:35. We'll start.
Okay po.
So we start first with our respiratory symptoms. There is a variety. There are a number of symptoms presented by pulmonary diseases, but we are going to concentrate mostly on three main symptoms, namely cough, dyspnea, and hemoptysis. Can you hear me?
Yes po, Doc.
So, okay.
Can you see the slides? Hello, can you see the slides?
Yes po,
Yes
Doc.
po, Doc. Yes, Doc.
Okay, thank you. So dyspnea, one of the most common symptoms presented by a patient seeking consult or admission because of a pulmonary problem. So the American Thoracic Society defines dyspnea as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So dyspnea literally means difficulty of breathing. So other descriptions used by patients are shortness of breath, out of breath, smothering, tightness in the chest. Okay? Pixon, Mark Jerome, are you around? Pixon.
Yes, Doc.
Okay. How would you classify dyspnea? Is it a symptom or a sign?
Symptom.
What do you think? Is it a symptom or a sign?
Symptom.
It is a symptom. Okay. John Roddy. Do you agree with Pixon, Mr. Pixon, that dyspnea is a symptom?
Yes, Doc.
Okay, so you're both correct. Dyspnea, when the patient says he's having shortness of breath, smothering sensation, or he's out of breath, this is a symptom. That is what the patient feels. But on the other hand, it can also be a physical sign, since dyspnea is often accompanied by dyspnea, increased respiratory excursions, tensing of the scalene and sternocleidomastoid muscles, flaring of the alveoli, and facial expression of distress. So dyspnea is both a symptom and a sign. Okay? Sometimes a patient will not be aware that he is dyspneic. The first clue that is given to the examiner is that when during your history taking, during the interview, your patient will pause for breath. Take a deep breath and then continue with his narrative. So it means that the patient has shortness of breath or has difficulty of breathing. Okay? Okay. So dyspnea has motor efferents as well as sensory efferents. The motor efferents, exemplified by disorders of the ventilatory pump, most commonly increased airway resistance or stiffness causing decreased compliance, increased work of breathing, or increased effort to breathe. It is also exemplified by fatigue muscles of respiration resulting to greater effort required to breathe. The sensory efferents, on the other hand, come from chemoreceptors in the carotid bodies and medulla, activated by hypoxemia, acute hypercapnia, acidemia. Stimulation of these receptors lead to increase in ventilation and produce a sensation of air hunger. Mechanoreceptors in the lungs stimulated by bronchospasm lead also to sensation of chest tightness. Metaboreceptors in skeletal muscles activated by changes in the local biochemical milieu of the tissue, which is seen during active exercise. Okay. Approach the patient during history taking. You should ask the patient to describe what the discomfort feels like, the effect of position, is there presence of infection, environmental stimuli on the dyspnea. It is important to distinguish several degrees ranging from exertional dyspnea to dyspnea at rest and orthopnea. Orthopnea being the most severe form of dyspnea. It is very hard to quantitate dyspnea. So you should ask your patient what activities, for example, will provoke the sensation of dyspnea. So exertional dyspnea, for example, when the patient says that when he climbs a number of steps in the stairway, after 5 steps, he will complain of dyspnea. Or walking several meters, the patient will complain of dyspnea. So describe the activity which will provoke the sensation. Dyspnea at rest is self-explanatory. Even at rest, the patient will complain of difficulty of breathing. While orthopnea, which is difficulty of breathing in the recumbent position, sometimes associated with mechanical impairment of the diaphragm, associated with obesity or asthma triggered by esophageal reflux. So we have said before that orthopnea is the most severe form of dyspnea, where patient is prompted to assume position at rest that elevates the head and the thorax towards the vertical. So orthopnea is described. The severity of orthopnea, rather, is described by the number of pillows which would elevate the head and make the patient comfortable. For example, 2-pillow orthopnea or 3-pillow orthopnea, meaning that 2 pillows is needed to elevate the head and make your patient comfortable. Okay, so the mechanism of orthopnea is poorly elucidated or explained, although said that the erect position lowers the domes of the diaphragm, permitting greater inspiratory excursions. Okay. So respiratory dyspnea, these are just the causes. It comes from disease of the airways like your asthma or your COPD. COPD like your emphysema and chronic bronchitis. Diseases of the chest wall like kyphoscoliosis, myasthenia gravis or Guillain-Barré syndrome, the presence of large pleural effusion. Diseases of the lung parenchyma, exemplified by interstitial lung diseases, autoimmune disorders causing increased stiffness and decreased compliance. Okay. So dyspnea is not the sole cause is respiratory. It could be caused also by cardiovascular conditions or coming from the heart. So dyspnea can either be from the heart or from the respiratory system or the lungs. So to distinguish the two, a cardiopulmonary exercise should be done. If at peak exercise, the patient achieves predicted maximal ventilation, demonstrated increase in dead space, or develops hypoxemia, or develops bronchospasm, so most probably the cause of the dyspnea is from the respiratory system. On the other hand, if heart rate is greater than 85% of predicted maximum, if anaerobic threshold occurs early, or if blood pressure becomes excessively high or decreased during exercise, or if on ECG ischemic changes are seen, most probably the cause of the dyspnea is from the heart or cardiovascular. Okay, are you still there, class?
Yes,
Joy,
Yes,
Doc.
ada pa ka mo? Nakabati ka mo? Can you hear me well?
Yes,
po,
Doc.
Doc.
Do not hesitate to interrupt me if you have any questions or anything not clear to you. You want clarified, okay? Okay. So, said before, quantitation of dyspnea, physical exertion needed to produce the sensation, and also you have to understand the patient's general physical condition. Ano ba niya? Aktibo ba niya? Bahin maluya hon lahiya. Dati na gud maluya niya. And then the work history. What is the work history? Ano niya? Executive, naglilining kudla, or your patient is very active, works as a stevedore, works as a laborer. Recreation habits. May mga nagte-tennis ba niya, nagba-basketball, or naggo-golf, or adahatubang ni TV, facing the TV the whole day. And then inter-individual variation of perception. Okay. So there are people who, even with severe disease, will only complain of mild dyspnea, while others with mild disease will complain of more severe shortness of breath. So inter-individual variation in perception. Okay. Another manifestation of respiratory disease is cough. It is an explosive expiration which provides essential protective function for human airways and the lungs. It is a sudden, forceful, noisy expulsion of air from the lungs, which may be single or paroxysmal. Okay, importance of cough. So without cough, we're at risk for retained secretions, aspirated materials predisposing to infection, lung atelectasis, and respiratory compromise. At the other extreme, there are side effects or complications from excessive coughing. One is exhaustion. This can be complicated by emesis, syncope, muscular pain, rib fracture, and can aggravate abdominal or inguinal area. Cause of cough, oftentimes due to respiratory disease. Okay. Baoy Kenneth, are you there? Baoy Kenneth. Are you around?
Yes, Doc. Good morning po.
Okay. How would you classify cough? Is it a voluntary or a reflex action?
Sometimes it's voluntary, Doc. Sometimes it's reflex.
What do you mean? Sometimes it's voluntary. Sometimes it's
Sometimes it's a form of reflex po, Doc.
so it is both a voluntary and a reflex action. Okay, voluntary. How would you explain that?
If you feel like po, Doc, para makatipo yung yung throat and you want to cough
Okay.
out.
So if you feel like coughing, you cough, di ba? Kung gusto mo umubo, di ba ubo, pwede. Or
Yes po, Doc.
okay, sige. So cough is both a reflex and a voluntary action. So as reflex action it has afferent pathways with receptors coming from the sensory distribution of your trigeminal, glossopharyngeal, superior laryngeal, and vagus nerves, while the efferent pathway comes from your recurrent laryngeal nerve and spinal nerve. So, sequence of cough. So, it starts with deep inspiration, followed by glottic closure, relaxation of the diaphragm, and muscle contraction. This sequence of events causes a markedly positive intrathoracic pressure compared to that of atmospheric pressure. It becomes positive. Intrathoracic pressure becomes positive. Tracheal narrowing also occurs, and sudden opening of your glottis causes rapid flow of air outside. So that is the cough. Rapid flow of air outside. So the causes of cough. One is inhalation, either smoke, dust, or fumes. Aspiration, upper airway secretions, gastric contents, or foreign body. Inflammatory conditions, inflammation, constriction, infiltration from tumors, compression of airway also from new growth. Parenchymal lung diseases like your pneumonia. Okay, so causes of impaired cough. Impairment of cough reflex can be secondary to decreased expiration or inspiration muscles strength, chest wall deformity, impaired glottic closure, or the presence of your tracheostomy, tracheomalacia, abnormal airway secretions, central respiratory depression from coma, or right after general anesthesia. So these causes will cause impairment of the cough reflex. Okay. Cough in long-term cigarette smokers lasts from seconds to few minutes, productive of mucoid sputum. Okay, cigarette smokers, they usually present with chronic cough. Cough, no? Tagmaiha. They usually come in with a history of cough. Prolonged cough. Naiha na, nag-iinubo because of, okay, sometimes this cough is babaliwala ignored by patients because okay, cigarettes, smokers cough. But take in mind that cigarette smoking is one of the predisposing cause of malignancy, bronchogenic carcinoma, or lung cancer. Cough with wheezing, shortness of breath, chest tightness after exposure to cat or other allergens. So there's an allergic component to this cough. Okay, duration of cough as clue to etiology. We say it's an acute cough if it's less than 3 weeks duration, commonly due to respiratory infection, aspiration, inhalation of noxious chemicals, or smoke. We say subacute when it is of 3 to 8 weeks duration, like exemplified by tracheobronchitis, post-viral tussive syndrome. Chronic cough is more than 8 weeks. Causes are inflammatory, usually inflammatory, infectious, neoplastic, or it could also be cardiovascular. In the history taking, you should ask, is it associated with symptoms suggestive of postnasal drip or gastroesophageal reflux? Is there fever? Is there sputum production? If sputum is present, what is its character? You should ask the patient's description of the sputum. Is it scanty or copious? Is it mucoid, purulent? What is the color? Is it yellowish, greenish? Is it bloody? Okay, those are the questions that you should ask your patient. Important is to ask for risk factors like cigarette smoking, risk for HIV, environmental exposure, and circumstances surrounding onset of cough. What makes it better? What makes it worse? Okay. Okay. There are other description of the cough. It could be brassy when it's unproductive and has a strident quality, commonly heard in patients with laryngitis and conditions that narrow the trachea or the glottal space, like, for example, neoplasms of the vocal cord. Whooping cough in patients with pertussis, characterized by long, strident inspiratory noise preceding the cough. Okay, so there are other descriptions in the book. Just look that up. Okay, next is hemoptysis, which is defined as expectoration of blood from the respiratory tract. This can arise from any part of the respiratory tract, from the alveoli to the glottis. It is important to distinguish between epistaxis and from hematemesis. Epistaxis, because it could be the bleeding could be from the nose, or the bleeding can be from the GI tract. So it is important that you should be able to distinguish the source of the blood. So hemoptysis may range from just a blood-tinged sputum to large volumes, which is life-threatening. Life-threatening because large volumes can cause flooding of your lungs, of course. Common cause is infection in medium-sized airways. So infection in medium-sized airways, that's why your COPD or chronic bronchitis is one of the more common, one of the causes of hemoptysis. But worldwide, the most common cause is still tuberculosis. Okay. In the history taking, determine whether it's blood tinged with purulent sputum. Is it frothy or front blood? Frothy is oftentimes associated with pulmonary edema. Okay. In my, what they call this, my clinic class, we have already discussed the difference between a hemoptysis and hematemesis, how to distinguish, how to differentiate whether the blood comes from the lungs or from the GI tract. We said that if it's from the lungs, usually there's a precedent history of cough, and then the blood is what? Bright red with sputum, and the pH is usually alkaline. Whereas if the blood is due to hematemesis or from the GI tract, there is usually a history of GI complaint like epigastric pain, recurrent epigastric pain, and blood is dark red, sometimes mixed with food, and then the pH is acidic. Okay, so massive hemoptysis is when the amount of blood expelled is from 200 to 600 cc in 24 hours. So it's massive. Ask about history of current or former cigarette smoking. Symptoms of respiratory infection like fever, chills, and dyspnea, and recent inhalation exposure, use of illicit substances. Okay. Next, we'll proceed while the going is good. We have internet connection. We proceed with examination of the breasts. Are you still there? Are you still awake, class?
Yes po, Doc.
Yes, Doc.
Okay. So, preliminary history. The patient's state of the breasts will depend on the following. Of course, the age, the parity, the nursing history, menopausal and menstrual history, previous history of surgery, example is oophorectomy, intake of drugs, and preliminary procedure. Importance of history is preliminary procedure to obtain patient's complete cooperation, because this is rather a delicate procedure, the examination of the breast. So you have to, of course, get the patient's complete cooperation. Okay. So the female breasts lie between the second and sixth ribs, between the sternal edge and mid-axillary line. 2/3 is superficial to the pectoralis major, 1/3 to the serratus anterior. Nipple and areola lateral are located lateral to the midline of the breast. Okay. Changes with age. During adolescence, the development of the breasts begin at puberty, usually. The pre-adolescent breast consists of a small elevated nipple with no elevation of breast tissue. At age 8 to 13, secondary sex characteristics become apparent. The breast buds appear and further enlargement of the breasts and areola occur. Okay. The stages of the breast development according to Tanner's sex maturity ratings. So stages 1 to 5, the stage 1 being the pre-adolescent breast with elevation of the nipple only. Stage 2, breast bud stage, with elevation of the breast and nipple as a small mound with enlargement of the areolar diameter. Stage 3, with further elevation or enlargement of the breast and areola with no separation of their contours. Stage 4, projection of the areola and nipple to form a secondary mound above level of the breast. And stage 5, the mature stage, with projection of nipple only. Areola has succeeded the general contour of the breast. This SMR or Tanner 6 maturity ratings is found in your base. Okay. Okay. There are only 2 maneuvers used in the examination of the breast. One is inspection, the second is palpation. Inspection can be done with the patient sitting or standing, with hands freely hanging on the sides, or ask your patients to put hands or arms on top of the head or raised above the head. Or the hands are placed on the hips or back, hands pressed together in front or on hips, have the patient lean forward. Okay, these maneuvers will give maximum view of the breast on the part of the examiner. So maximum view of the breast, patient's breast. There are times when you cannot ask the patient to stand. So do not insist on your patient standing. She cannot rather. So you can examine the breasts with the patient lying on her back. So with her on her back, the hands should dangle towards the floor, or ask your patient to put her hand on top of the head. Okay. So inspection, note for symmetry and nipple levels. So normally the breasts are symmetrical, the same size, the nipples the same level, the breast the same level. But if this is not, there are occasions when the breasts are asymmetrical, rather one may be bigger than the other breast. But if this occurred recently, it should be suspect. But if this has been noted years before, since adolescence, so it may not be a cause for concern. But if this is a recent development, this should be examined thoroughly. Okay. Take note also edema and venous engorgement, retraction and dimpling. Retraction and dimpling means there is a mass underneath pulling the structures above or on top of that. Presence of lumps and abnormal masses, nipple inversion or retraction. Usually the nipples are everted or outward. So recent inversion or retraction should be suspect. Protrusion and peau d'orange, or how do you pronounce that? That's French, no? Orange peel appearance of the skin, which may be secondary to edema. So lymph node enlargement in supraclavicular and axillary areas. Okay. Okay. The second maneuver is palpation. This is best done with the patient in recumbent position. Pillow should be placed under the shoulders. So this will expose the breasts to the maximum, no? So when you palpate the medial half of the breast, the inner portion of the breast, no? The arms should hang down on sides. Palpate gently, quadrant by quadrant. So you divide the breast into 4 quadrants with 2 bisecting lines running through the nipple. So by there you can divide your breast into 2 upper quadrants and 2 lower quadrants. So inner and outer quadrants below. So 4 quadrants. So when you palpate, feel for lumps. Take note of the temperature. Okay, it could be warm, means there is the presence of infection. Turgor, skin turgor, thickness of the skin. Thickness of the skin can be secondary to edema. Thickened skin can be secondary to edema. To define borders accurately, poking finger should palpate from normal towards mass. If a patient tells you that there is a mass, she was able to palpate on the inner on her breast. When you palpate, be sure to palpate from the normal skin towards the mass. So normal towards the mass in order for you to be able to delineate well the borders of that mass. Okay? So to delineate the borders of that mass, palpate from the outside going towards the mass. From the normal portion, normal part of the breast towards the normal mass. Ano ito? So, when you are able to palpate for the mass, describe the mass as to the following. Consistency. Consistency, is it cystic? Is it firm? Is it hard? So, those are the description. Stony hard, cystic, soft, what else? Firm. Consistency. Texture, is it smooth or gritty? Discreteness. Discreteness meaning, can you delineate well the borders? Or is the mass well confined or napakadto ito normal? You cannot determine the borders because ato nat mga normal tissue. Okay, that's discreteness. Tenderness, when you put pressure on the mass, does the patient complains of pain? Mobility, if you try to move, is the mass fixed or mobile? Mamumove nimo, you're able to move the mass. And then measurement in centimeters. Diameter, how many cms? 2 by 2, 4 by 4, 1 by 1 cm. That's how you measure. And then palpate the nipple, squeeze, note for discharge. Normally, there is no discharge except when, what? When your patient is lactating or if there is infection. Okay. Never fail, okay? It is always part of the examination of the breast to examine also the axilla. Okay? Palpate the axilla looking for lymph nodes or any mass there in the axilla. For example, if you are examining or palpating the left axilla, the arm is relaxed by supporting it with the left hand of the examiner. If you are right-handed, support the arm of the patient with your left hand and then use your right hand for palpation. Slide your palpating fingers to the apex of the axilla with arm abducted. Slide down the rib cage of the lower axilla. Okay. So from the apex going down, try to palpate for any lymph node. Do it also on the right. Compare. So both axilla should be examined. Just that the both breasts, just because your patient complains only of mass on the left breast, you forget to examine the right breast. So both breasts should be examined. At the same time, both axilla should also be examined. If you are able to palpate for a node, take note of the size. Again, consistency, mobility, the location, fixation to underlying structures. Okay. To localize breast findings, divide your breast into 4 quadrants with lines crossing the nipple or visualize the breast as the face of a clock. So imagine, relo. Okay? So 12, ada igbaw, 6, 9, and 3. Tapos may numbers ito, ano? For example, is lesion at 4 o'clock and by distance in centimeters from the nipple. Okay. For example, how do you describe? Okay. Kayla. Miss Daa, are you there?
Yes po, Doc.
Okay. For example, you were able to palpate. Kumbaga, nakapalpate ka 2 by 2 cms mass. Benign lahiya, benign mass. 2 by 2 cms at 4 o'clock. How are you going to go about in your recording? In the reporting? Sige daw. At 2 by 2 benign mass, benign lahiya. 2 by 2 benign mass at the kumbaga harilo ada 4 o'clock. 4 o'clock, sigunta na lang at 2 cms from the nipple. Sige daw. How are you going to describe that?
2 by 2 mass at 4 o'clock.
Sige, ano pa? Benign lahiya. Benign mass lahiya. Dirihiya, not malignant.
Benign 2 by soft. O dire. Benign 2 by 2 mass at 4 o'clock.
You don't say benign because you're not sure yet unless you do a histopath. But supposing this is a benign mass, what would be the description in your recording? On your history?
If it is soft po, Doc.
Hmm?
I'm not sure po, Doc.
Sige. Okay. Korea, are you there? Can you help out? Mr. Korea, are you there? Present? Maray na? Absent na? Babon.
Here po, Doc.
Okay, so, sige na, example. A benign mass at 4 o'clock, 2 cms from the nipple. How would you describe that in your recording? Ano't mga description? How are you going to describe that mass?
Mass with smooth edges and able to be moved slightly.
What else? Sige, proceed.
Seen at 3 o'clock, 2 centimeters away from the nipple.
Okay, correct. What else? What else? Okay, so thank you. So, an example of how you are going to go about in the recording is,
Excuse me po, Doc.
2 by 2 cms in diameter. O ako na ito pag-describe. So most probably, because of the description, most probably benign unless, but we cannot be sure, no? Unless a histopath is made, performed. Okay?
Excuse me po.
Pardon, I cannot hear you well.
Doc,
Must be something wrong with my,
yung description mo po kanina, it was choppy po. We didn't hear it well.
Sorry, hindi ko marinig. Can you hear me well?
Danay po, Doc. Nawawara po't imo audio po.
Oh, no, there's something wrong siguro. Sige, anyway, we'll proceed. Lymphatics. But you can see my slides. You can see my slides well.
Opo, Doc.
Okay, sige. So going to the lymphatics, there are central axillary nodes located along the chest wall, midway between the anterior and posterior axillary folds. There are three groups of lymph nodes, okay? One is the pectoral or the anterior group, which drain the anterior chest wall and most of the breast. Two is subscapular or the posterior group, drains the posterior chest wall and part of the arm. And the lateral group, which drains most of the arm. Those are the lymphatic, Okay, let's go to the nipple. It's pigmented, pink, red, dark brown. This depends on the complexion of the patient or the nationality. So it could be pink, red, dark brown, pigmented. Usually or normally it is everted. Usually no discharge. And symmetrical. Normally points outward and often downwards. Recent fixed flattening or depression suggests nipple retraction, which is suggestive of carcinoma. Okay. So do you have any question? Do you have any question? Do you have any question, class?
Hello, Doc.
Any question?
Hello, Doc. Can you hear me po?
We cannot hear.
Doc, will chat na lang po.
Sabog kasi ang sound. I cannot hear you well.
Excuse me po, Doc. Hello, Doc.
Hello. Yes. Sabog at iyo Ano ko na question? Anybody?
Doc, okay lang po ba magpa-otro po kung paano po?
Paano, ma'am?
Sorry po, Doc. Okay lang po ba magpa-pardon po pag-describe po possible benign mass po 2 centimeters away from the nipple po ang kanina po?
Oh, it was just an example. Example man lang. Mas,
Hello, Doc. Dire po kami nabati yan.
Di ka mo nabati?
Hindi mo ka-describe.
Ito. Can you hear me? Can you hear me?
Opo, Doc.
Okay. Mass palpated at 4 o'clock. 2 cm from the nipple. Which is non-tender. Freely movable. Smooth. Firm. With well-delineated borders. Measuring 2 by 2 cm in diameter. Naklaro niyo?
Opo, Doc.
Okay.
Thank you.
In contrast, kung masiring, kung bagan, iton mas nga masiring ka mo nga. A mass palpated at 4 o'clock, 3 cm from the nipple, which is non-tender, fixed, hard, with borders not well delineated, measuring 2 by 2 cm in diameter. So, magsususpect na kamo bangin inihiyang malignant because of the consistency which is hard and the borders are not well delineated, meaning na-encroach na hiyang adtuhan mga normal tissue bahan breast. Okay? Plus, of course, may ada mga other like edema, may mga retraction of the nipples, may and pudorang, so those are other findings consistent with malignancy. Okay, any questions? No more? We may not have lecture tomorrow because diba an examination of the breast is scheduled for tomorrow. But yung po nalayan na kay internet bigha balay, questionable internet connection. So while we have internet connection now, gipadayon ko na laan I continued with the lecture of the breast. Tomorrow we may not have lecture. Next week na Tuesday. Okay?
Okay po, Doc.
Okay, by the way, your bi-monthly starts November 15. The coverage will be from history taking up to the lecture of Dr. Mambulaw, head and neck, examination of the head and neck.
Yes po, Doc.
Okay, the lecture of Dr. Nuevo and this lecture is not included for the first bi-monthly. Okay? Do you have any more questions? Because we're going to adjourn now. No more? Okay, no more questions? Sige. So, thank you and good morning.
Thank you po,
Thank you so much,
Thank you,
Doc.
Doc.
Thank you, Doc.
Thank you po,
Thank you,
Doc.
Doc. Good
Thank you,
morning.
Doc.
Salamat, Doc.
Thank you, Doc.
Thank you, Doc.